Okay, thank you. To be honest, I didn't know what I could talk to you guys about, where you would learn something, because despite what Ravi says, I'm not that bright. So I just don't know what I can teach you. But anyway, it was put to me that I could talk about cranial nerve palsies, and I kind of realise now that was because everything else had already been spoken about. So you've been very good to concentrate this long, and I won't keep you too long. And I'm kind of reliably informed that you guys know this sort of neuroanatomy really well, so I probably don't need to go into much detail. Um, so the cranial nerves are nerves that arise largely from the brainstem. I'm told, more or less, that there are 12 of them. I think that's right. Um, and some of them are purely afferent nerves, so they're taking sensory information to the brain. Some are efferent or motor nerves. Some are a mixture. Some have autonomic nervous system function. Um, and the important ones for ophthalmology, well, obviously the optic nerve is the most important one, but 3, 4, 6, 5, and 7 also kind of impinge on our sort of practice. So I'll just kind of quickly run through them. The first is the olfactory, which obviously caters for smell, and that goes from the roof of the nose to the hypothalamus. Not really important to us. The optic nerve, I'm not really going to talk about that, even though that's probably the most important. Cranial nerve 3, or the oculomotor nerve, has a role in movement of the eye, the lid, the pupil, and accommodation. And the anatomy of the oculomotor nerve is there are nuclei within the midbrain. The nerve passes forward through the cavernous sinus, where it's in close proximity to the internal carotid artery and the posterior communicating artery in the circle of Willis, which is kind of important, through the superior orbital fissure. And then there are two divisions, a superior and inferior, that supply the extraocular muscles, or some of them, and also via the ciliary ganglion to the ciliary body and pupil. The fourth cranial nerve, the trochlea, supplies the supraoblique muscle. It's a little bit different in anatomy in that it arises at the back of the brainstem, and it's got quite a long intracranial course. Goes through the cavernous sinus and again through the superior orbital fissure. And it's the kind of long intracranial course that makes it particularly susceptible to trauma. The fifth cranial nerve is responsible for facial and ocular surface sensation, and also the muscle of mastication, chewing. And there are three divisions. Obviously, the ophthalmic artery is the important one for us. Sixth cranial nerve supplies the lateral rectus muscle. Its nucleus is in the dorsal pons, and it runs over the angle of the petrous temporal bone, where it goes through a kind of right angle bend, and then through the cavernous sinus and superior orbital. The facial nerves are responsible for movement of the facial muscles, obviously, also responsible for lacrimation, taste, and there's a small area of sensation in the external auditory meatus or canal, where it supplies sensation to that part of the skin, which is important. There is a condition called Ramsay-Hunt syndrome, where if you have herpes zoster infection, you can get blisters in your ear and a facial palsy. It goes through the stylomastoid foramen. It's got lots of kind of different connections with other nerves, and then passes through the parotid gland, and there are 5 main branches supplying the muscles of the face. I won't kind of go into great detail in the others. The vestibulocochlear nerve obviously is a little bit related to ophthalmology because it's important in equilibrium and nystagmus and that sort of stuff. The glossopharyngeal nerve supplies pharyngeal muscles and also sensation and taste to the pharynx and the posterior tongue. It also supplies a bit of sensation to the meninges of the brain, which is when you get brain freeze, that's why, because it's that part of the throat that's been cooled down. The vagus nerve is basically responsible for autonomic functions, so body systems, It also supplies the recurrent laryngeal nerve to the vocal muscles, which is the usual sort of anatomic cause of it. The spinal accessory, or the accessory nerve, sometimes called the spinal accessory nerve, supplies muscles of the neck, sternocleidomastoid and trapezius muscles. It's exactly in the upper part of the spinal cord, and there's some debate about whether it's really a cranial nerve. This is controversial, so I know you might want to discuss this amongst yourselves, but it kind of comes into the cranial cavity through the foramen magnum and then back out again. And the final one is the hypoglossal nerve, which mostly supplies muscles of the tongue. Speaking of controversy, I mentioned about the the vagus nerve and the recurrent laryngeal nerve to the vocal cord. There is kind of Darwinists believe that in a giraffe, which kind of has the same anatomy of the rest of us, the vagus nerve goes from its head all the way down to its chest, and then the recurrent laryngeal nerve goes around the aorta on the subclavian artery, back up to its head again, and that it's not really an argument for intelligent design, you know. Yeah. So the important nerves from our perspective are, and I realise they're not in kind of numerical order, but the oculomotor, trochlear and abducens nerves and the trigeminal and facial. Third nerve palsies, patients usually present with double vision, ptosis. The eye typically is kind of down and out because the only muscles are working are the lateral rectus and the superior oblique. And they may or may not have a dilated pupil as well. And that's kind of important because the pupil fibres within the nerve are fairly peripheral or superficial in the nerve, and they're more susceptible to compressive lesions. So if you have a patient with a third nerve palsy and the pupils involved, it's a little bit more concerning. You're still going to have pupil involvement with a microvascular disease, but we take pupil involvement a little bit more seriously. On the other side of the coin, if you've got a patient who presents with a dilated pupil and they have no ptosis or extraocular muscle imbalance, they don't have a third nerve palsy, they have something else, whether it's pharmacological or they've got AD syndrome. So you don't get third nerve pupil dilation without other muscle involvement. Often third nerve palsies are from microvascular disease, particularly diabetes, but other kind of cardiovascular risk factors. They can be from compression, and the kind of thing we worry about is an aneurysm of the posterior communicating artery. They can happen from trauma and from stroke. And the investigation depends a little bit on the suspected etiology. If you've got a younger person and they've got pupil involvement, they will need some sort of neuroradiological investigation. If they're an older person, they've got diabetes and they've got other kind of vascular risk factors, and the pupil's not involved, that might not be necessary. And if you think they might have an aneurysm that's pressing on their third cranial nerve, they just need to go to ED. You know, they don't pass go, they don't get $200, they just go straight there and they're investigated and managed accordingly. In people where, you know, it's a more benign etiology, they often will recover spontaneously. It might take weeks or even months, but it usually does get better. And, you know, if we've excluded concerns, then the simplest is just to try and alleviate their symptoms as best as possible. Usually that means occluding one eye. I don't think it really matters which eye you occlude. There's kind of theory that you, in fact, should occlude the good eye, and that encourages recovery of movement. I don't think that's really true. In a child, you'd obviously be worried about amblyopia with excessive patching, so you might alternate the occlusion in children. Prisms can be helpful, although a little difficult if they've got more than one muscle involved. And if the recovery is kind of incomplete, then it's possible to have squint surgery to try and improve their alignment. Usually it won't get rid of diplopia entirely, but it can move their field of binocular single vision into a position where it's more practical or more useful. But there's this condition of aberrant regeneration, which seems to happen more with, well, I guess because there's more muscles involved, with third nerve palsies where when there is recovery, sometimes the fibres get redirected to the wrong muscle. And you have kind of funny effects like the lid going up or down with horizontal movements, or the pupil changing according to directions of gaze and stuff. Aberrant regeneration doesn't happen with microvascular disease. So someone who's thought to have had microvascular disease and they're developing signs of aberrant regeneration, you've got to really think again. Also, if they present with a third nerve palsy which already has aberrant regeneration, that's thought usually to indicate a slow growing tumour compressing the nerve. And that's a patient with if you look in the middle picture in primary gaze, it's ptosis, and when you lift up his lid, the left eye's kind of out a bit, and it doesn't adduct in the left pictures, and it doesn't really go up and down either. His pupils are a bit dilated, so it's a bit unhelpful. So that's, a complete third nerve palsy, really. As far as the fourth nerve goes, usually people with that present with vertical diplopia. Most of them are from trauma. You can get, microvascular disease or other causes, but trauma is the thing the fourth nerve is particularly vulnerable to. And sometimes you can have bilateral fourth nerve palsies, which is a bit funny. They get of an alternating hypertropia, but typically they get a lot of trouble with cyclotorsion, more so than unilateral palsies. Fourth nerve palsies are sometimes congenital, and often kids with a congenital fourth nerve palsy will have an anomalous head posture where they tilt their head and a large vertical fusion range. And mostly with fourth nerve palsies, we don't always investigate them. The other kind of classic test to kind of confirm a fourth nerve palsy is this Balchowski, or a three-step test, which is kind of sometimes described as being able to decide which vertically acting muscle is the one that's the problem. But really it can get a little confusing, and it's more to confirm that the features are consistent with a fourth nerve palsy. As far as management goes, usually they will recover, and again, patching one eye and using prism can be helpful. Surgery is a bit more effective for fourth nerve palsies because you can weaken the direct antagonist fairly effectively, and they kind of cancel each other out. So even if they've got some movement of the superior oblique, or if they've got none, the net effect tends to be the same with the same operation, which is a little unusual. This is a patient with a fourth nerve palsy. It's a little tricky. If you look in the middle picture, it kind of looks like he's got a left hypotropia, but in fact he's fixing with his palsied right eye. And you can see that the vertical deviation is worse in left gaze, and there's a little bit of underaction of depression in adduction. And this is an example or a series of pictures showing the Balchowski. Well, the other interesting thing is he's got a little bit of a head tilt, and patients tilt the head towards the side of the palsied eye. And in the three-step test, in this case, there's a left hypertropia, which is worse in right gaze and worse when you tilt the head to the left. Sixth nerve palsies present with horizontal diplopia, which tends to be worse for distance, and there's limited abduction of the eye. The sixth nerve can be compromised by raised cranial pressure because of its course angled over the petrous temporal bone. So sometimes that's a false localizing sign, and the problem might be nowhere near where the course of the sixth nerve is. So it's always worth looking at these people's discs for evidence of papilledema. And it can occur with tumour, not necessarily involving the nerve, as I say, but all the other kind of culprits. Sometimes in children it's thought it can be a post-viral or after viral infection. And again, if we rule out the kind of sinister causes, then usually we can expect some recovery. Botox has a little bit of a role in with lateral rectus palsies because you can temporarily weaken the medial rectus, and again they can kind of cancel each other out a little bit. And it's thought that can help prevent tightening of the medial rectus muscle and what's called a spread of comitance, where even when the lateral rectus improves, it's still kind of overpowered by the medial rectus. And this lady has a left lateral rectus palsy and obviously can't abduct the left eye. As far as the fifth nerve goes, usually you don't have a complete palsy, but you can have partial reductions in sensation, either on the face or just to the eye itself. And the danger with that is that the sensation to the cornea is very important to its health and the health of the epithelium. And if it's compromised, you can develop a neurotrophic keratitis where not only is the eye susceptible to recurrent kind of minor trauma and there's not such stimulus to blink, but the trophic factors that the nerves release to keep the epithelium healthy are lacking. And that can lead to corneal ulceration. The most common situation is people with herpes, either zoster or herpes simplex. But sometimes you can have similar sorts of problems from trauma or from intracranial surgery if the nerve's been damaged. And the main thing is keeping the ocular surface healthy as best you can with lots of lubricants. Sometimes we do tarsorrhaphies to kind of close the palpebral aperture a little bit, provide a bit more protection. Things are really bad, conjunctival flaps. There is a process of neurotization where you can redirect sensory nerves from wherever they're going to and surgically put them under the conjunctiva near the limbus, and the fibres will kind of grow into the cornea. Obviously, it doesn't work if you've got a complete kind of ophthalmic nerve palsy, but if just a corneal sensation compromised, you can return some sensation from transplanting either the trochlear or supraorbital nerves. And you can see this girl's got typical zoster blisters on her brow, and that extension down onto the side of the nose indicates the nasociliary branch of the ophthalmic divisions involved, and that's the branch that supplies the surface of the eye. So if you've got zoster that goes onto the side of the nose, involvement of the eye is much more likely. And that's a neurotrophic keratitis, and you get that kind of rolled, non-healing epithelial edge. Obviously this is bad because there's a bit of hypopyon as well. Facial nerve palsy, the issue obviously is corneal exposure really, and so inability to close the eye fully. They often get epiphora because there's ectropion as well. And the commonest cause really is Bell's palsy, which is thought to be a post-viral kind of inflammation. Ramsay-Hunt syndrome I mentioned before, which is like a Bell's palsy, but with herpes zoster in the seventh nerve as the cause. Sometimes it's from tumour, either directly, the seventh nerve is very close to the vestibulo-ocular nerve, so an acoustic neuroma can sometimes damage the nerve, or more importantly, surgery for that sort of thing can, or parotid surgery sometimes. For Bell's palsy, often oral steroids are used, lots of lubrication, protection of the ocular surface. I don't think putting pads on is very helpful. Usually if I want to have the eye closed at night, I'd say you should tape the lid directly. And sometimes we, again, narrow the palpebral aperture with a tarsorrhaphy or medial canthoplasty. And there are metal weights, gold or other materials that can be implanted into the upper lid and help the lid to close. They're obviously not effective when you're lying down, but they do help to improve the blink when people are upright. And that's a patient with a left foot palsy. There's a whole lot of brainstem syndromes where you can get combinations of things, and they're all kind of interesting, and they've all got, you know, eponymous names, but they're all rare. And these people are sick, you know. They won't come to you saying, "Oh, I can't move my arm and leg," you know, kind of thing. So they're kind of interesting, but, you know, not even in my territory, let alone yours. And there's all sorts of other masquerades that can look a little bit like a cranial nerve palsy, but they're not. I guess the commonest being myasthenia gravis, although that's not common, which Ravi mentioned before. And it's an immune disease where there are antibodies to acetylcholine receptors on skeletal muscle. And a lot of people, at least initially, maybe 25%, you know, eventually too, will only have eye involvement. They won't have systemic muscle involvement. It's worth asking them, you know, can you brush your hair, or can you hang the washing out without your arms getting too tight? But sometimes it's just ocular involvement, and it can be any sort of pattern. It can look like just one muscle, or it can be multiple muscles, and it changes over time, so it can be a bit confusing. Because it only affects skeletal muscle, they never get pupil involvement. So if you've got pupil involvement, it's not myasthenia gravis. The other feature is the fatigability. So if they've got ptosis and you kind of get them to look up and hold it there for a while, you see the lids just creeping down. And then when they rest for a while, it's a bit better. I think Ravi mentioned the ice test, where you can put an ice pack over their eyes for 5 minutes or so and see whether it changes. It's kind of helpful if you can measure their ptosis, or if they've got some sort of muscle deviation that you can quantify, because you can kind of then prove that it's changed by doing that. The Tensilon test is a test where they're given an injection of an agent that blocks free uptake of acetylcholine, and it's like the ice test. Their symptoms will improve miraculously for kind of 10 minutes or something after the injection. Usually the treatment is with a drug called mestinon, which is like the drug that's used for the Tensilon test, but it's an oral medication which has a much longer duration. Probably don't need to talk too much about the other things. Sometimes thyroid eye disease can present with diplopia, but they'll have other features. There are ocular myopathies. Generally, they don't have diplopia because they're fairly symmetrical. Duane syndrome is an interesting one, which I'm sure you all know about, which is essentially a lateral rectus palsy, but it's from failure of development of the sixth nerve. So the lateral rectus, which is kind of puny and not very strong, it often has co-innervation from the oculomotor nerve, and the kids with that may have strabismus, but often they don't. They often have fairly normal binocularity, but have the feature that their palpebral aperture changes when they adduct the eye. So it gets narrow because there's retraction of the globe, because the lateral rectus just won't let go. I would also just kind of mention that sometimes people with giant cell arteritis can present with what looks like a muscle palsy. That's a patient with thyroid eye disease. So if you've got someone who presents with double vision, the history can be helpful at kind of onset. If it's fairly rapid, that's usually kind of microvascular disease or a stroke. Well, they have headache, which can be helpful. People with kind of benign disease still can have headache because the palsy itself can be painful. Other neurological symptoms which might kind of indicate where the pathology might lie. You need to do a fairly thorough ocular examination, and as I say, also looking at their optic discs, cover tests obviously, and the kind of 9 cardinal positions of gaze. Sometimes if you want to kind of quantify things, mainly when you're looking at ongoing improvement or otherwise, then using Maddox rod in different positions of gaze and kind of measuring the strabismus or a Hess test can be helpful, but I wouldn't do those in everyone. Most of them are going to need some sort of neuroradiological investigation, and the money's usually with an MRI and with contrast. Once their kind of underlying cause is diagnosed and managed, they need occlusion of one eye generally for symptomatic relief. I think prisms can be helpful for those kind of 6 or 12 months when you're hoping things are going to get better, and often Fresnel prisms, partly because you can have more prism in those than you might put into glasses, but also as things change, it can be altered. And squint surgery is a possibility if they don't fully recover in the long run. That's about all I have to say. Has anyone got any things they want to ask me? No? I don't know if I have to go through these or not. It's up to you. Do you want it? They're easy, I guess. I think, anyway. So a patient with ptosis, a divergent squint, unequal pupils has got trochlear nerve palsies. Most common cause is dry. So if someone's got diabetes and no kind of sign of a tumour, what would be the kind of first thing you would do? See, yeah. So you want to talk to them about their blood sugar control and their blood pressure and that sort of stuff. And if you have a patient who you think might have myasthenic gravis, do they all have systemic muscle weakness? No, they don't. They shouldn't have abnormal pupils. They tend to be worse throughout the day, so best when they wake up and worse at the end. But they often do have ptosis, and usually is worse when they're in upgaze for any length of time. And if you've got a cranial nerve palsy and all the investigations really don't show anything, what's the likely outcome? Really, the prognosis is pretty good. Most people will recover almost fully, but it takes quite a long time. Okay, thank you.